Good afternoon, dear colleagues. I'm very glad that we have almost the full room, though it's quite already the afternoon of the event. So I think this topic of artificial intelligence is still quite crucial and of interest. And we start the session related to the technologies about artificial intelligence, how we can use these technologies in healthcare, in medical care. So it's very wide meaning of this word. So we have quite a lot of specialists from Russia. So we have guests from abroad. It will be very interesting to hear from them what's topical right now in the world related to this topic. What are the expectations? How did the expectations change during the last 3 years? What are the practices in healthcare in the world? What can we use here in Russia? And what we can apply to our circumstances in medical care. So the Russian system of healthcare is quite large, quite spread across the huge territory. So the use of artificial intelligence technologies, automation of the doctor's work is very topical for us, because we have regions with quite uneven density of specialists in different who work with different diseases. Sometimes we have a lot of them, in some places almost none. So I suggest that we start the session and let's give the floor to experts. And our first expert is our colleague from Australia, director of Boston Consulting Group, the digital solutions in healthcare, Robin Mann. Robin, please, we heard your very interesting report about Internet of Things. Now we will talk about another technology, about artificial intelligence. Could you please tell us what practices in Australia, in the world, what does BCG see in this area of artificial intelligence development? What are the expectations? Maybe how did they transform during the last 3 years when there was a very big hype of this technology? Now it's sort of going to be down. Now we are interested to see the real business, real practices. So sort of this efficiency plateau.
Thank you. Thanks very much for the question and for having me here. It's a great pleasure. So I guess the first thing to say is that when I'm thinking about artificial intelligence, it's really just a way of processing a lot of data with lots of algorithms and getting greater insights. So we see AI in today's practice as just another tool that we would use to identify, diagnose, and then develop solutions to help solve particular problems that one of our clients might have. Some examples of the type of work, just briefly, and then I'll talk, I think, about something that I was involved with very recently, just before Christmas. So we have used, BCG has a team called Gamma that is expert data scientists, and they're the experts in artificial intelligence and how it's applied. They've used that with a government payer client, and they've looked at claims that have come in for various procedures and work that have been done, and they used artificial intelligence to analyze that data and look for areas of discrepancy, and probably not a great thing to talk about in front of a medical audience, but there are some doctors who are slightly more colorful with their claims than their colleagues, and are reaping the rewards of that. But now these tools can actually even things out a little bit. More on the care side, so triaging patients. It's now possible to use artificial intelligence with the data and the patient's entered data to identify which patients don't need to be given emergency treatment and which do, so that you can divert them to better facilities. And also looking at predictive risk, so identifying who's at risk, and particularly for points of care that cost a lot. So if you're readmitted into a hospital, when you discharge someone, who's at risk of coming back in, and that's increasingly important as we try and compress the length of stay. There's more chance that someone is going to bounce back in again. The particular work that I was involved with, our client in Australia was suffering, as many are, from a massively increasing demand in emergency services. And despite a continued and ongoing investment in new emergency departments, or accident emergency, I'm not sure what you call them here, new emergency departments, the performance of the system measured by how long you're waiting to see a doctor, how long you're in the ED for, and where you go afterwards, was continuing to decline. And there were many people who were coming up with ideas for how that might be solved. But it was nothing was being tried at scale because it was expensive. So typically more and more hospitals were being built and more business cases for supersized emergency departments, which is seen as being unsustainable in the health system. So we were asked to help, and we built a digital twin of the emergency services that covered everything from ambulances through to the emergency departments, and we then used the analytics with that digital twin was driven by artificial intelligence and machine learning, which was able then to simulate different models. And within the space of about 3 days, we were able to simulate different alternative care models, facilities that people would go to, which patients would go to which facilities, and we were able to narrow down the selection of potential solutions and understand the impact of those solutions very quickly. So we determined that there were two new facilities, one was an urgent care setting and one that was outside the hospital system, but the other one was a medical admissions unit within the hospital system, would allow the patients to be diverted and treated appropriately, and that would then allow the business to meet its targets and reduce and meet the performance targets, but also at a much lower cost than building new emergency departments. So that also means that you don't need to test or try something out anymore. You can just try a new model, run it through the simulator, and then out pops the answer. So the next phase of that work is actually to look at how can we use the simulations to, in real time, actual time, to inform operational decisions on the ground. So one option would be around helping ambulances determine what's the optimal emergency location to take the patients. Another one would be what staff do we need today to best manage the people that are coming in, as well as longer term planning decisions for infrastructure, that kind of thing.
Robin, спасибо.
Thank you, Robin. One short question. So clinics come to you as to a big consulting company and ask for help, ask to improve their business processes, to offer some better solutions. And you start with some pilot projects like what you told us about. Is it some actual practice or some working projects, so some Australian hospitals use these technologies, or it's just been a pilot project?
So I guess the answer to that question is that if we're talking about artificial intelligence in particular, what I described is kind of like quite new. Used in hospitals, but it's quite established in other industries. So in mining and in retail, these types of technologies are used all the time. In the Australian system, we use advanced analytics for many different purposes. There's examples of, I think I mentioned this actually yesterday in the clinical decision support section, with diagnostic imaging using AI to do diagnostics. The AI is not doing the diagnostics, it is helping to prioritize the workflow of the radiologists. So you can, a number of different, say mammograms are done, these ones seem to be high risk, these ones get processed first. So the turnaround time is accelerated for that type of thing. That's an example. Yeah.
If we speak about rentgenology, about radiology, so for how much time have this practice in Australia already used in doctors' work to help them to diagnose? For how long? 2-3 years ago, when it wasn't, or just maybe a year ago, this project started to become typical in doctors' practice?
So the example there is actually in the a client with the United States. So that was about a year ago they put that in place, and now it's part of the process they do for the radiology. Yes.
То есть вы находитесь на этом пути.
So you're on your way. So you're on your way. You're on your way to implement it.
Спасибо большое.
Thank you, Robin. It was interesting. Now I'd like to go to the venturing area. Among our guests, we have Nicholas Mark, so managing director and partner Intermountain Ventures, so representative of the U.S. Foundation, who also has some clinical part, so the healthcare related, and the venture foundation. So Nicholas, please tell us what kind of projects are in focus, or what are launched, and what are implemented and really works. And so what do you look at in terms of investments? What are the most important parameters when you think about funding of such project? Just a couple of words, quite shortly. Yes. And I'd like ask to all the speakers to be quite short, no more than 7 minutes for report.
Sure, it's terrific to be with you, and thank you so much for the opportunity. It's interesting for us. We found it feels like every new startup that we look at from a diligence perspective has some AI piece in their pitch deck. And we find that about 80% of those are not able to replicate what they're claiming in their pitch deck. So that's a problem for us, obviously, on the venture side. So we look pretty concretely at looking at real results and where people have real technical action within artificial intelligence and the application of that. We think some of the pioneering work by Geoffrey Hinton and others at the University of Toronto were pretty foundational for this. And there's been a number of things thematically that's been happening, particularly across the United States, that's made artificial intelligence a possibility. And that's really the proliferation of data and also EMRs. If you go back to 2010, about 10% of the United States had an EMR in place. They had penetrated the United States about 10%. If you go to 2018, we're at about 85%. What that means is we have a lot of data, and now we can get to the application and analytics around that data. And so that's very intriguing and exciting for us. One group we follow very closely is Google DeepMind. They've been very engaged in this. I think most folks have read their reports. They're showing some really interesting efficacy around application within healthcare. The real inflection point was the AlphaGo project, where they actually had machines outperforming humans in chess matches, and that's proliferated where we can actually see machine performance outperforming humans from a medical perspective. And it's everywhere. We've seen it with imaging, we've seen it with life sciences, and now we're seeing it at the point of care. One example I just wanted to mention was a company called Javion that we're very familiar with. Javion's recently reported with Mercy Medical Center in the United States. They're based in Canton, Ohio, that they've announced that they've reduced readmission rates by about 20% after implementing their algorithms at the point of care. We think where this goes from here is really going to be a proliferation of algorithms inside of a lot of different software, and this will really be clinical decision support software that starts to get integrated. The key for us is it has to be integrated inside of an EMR for our clinicians to get tactical action, where they're being given recommendations, and they can give patients recommendations as well to really improve outcomes and reduce the overall cost curve.
Примеры хороших.
Good examples. How do you look now at the investments in the US in AI in health, in medical care? Do you think this hype on investments is already over, or it's still haven't started yet? So what do you think about the appearance of new solutions and funding?
So our personal opinion is we think it's just getting started. We think there was a couple different hype cycles. The first hype cycle was a consumer hype cycle based on digital health that occurred in 2010. We've seen an inflection where consumers haven't adopted technology as quickly as they thought. We've seen a gravitation back towards working with payers and providers within the US system. And so we're seeing a resurgence of funding around that. We also believe that we have more data, which is incredibly important to get to good data sets, structured data sets, to really test and validate these algorithms. One example that's probably worth highlighting, in 2018, there was a study at Stanford that tested AI algorithms against radiology, and they found that I think it was 420 x-rays. The machine could complete that in about 90 seconds, and it took doctors several hours to do the same work, with a higher level of accuracy being performed by the machine. So we think we're really excited about it. It does get back to validation for us, but we think we're really at an inflection point for investment inside of artificial intelligence. The latest we've heard is, from a market size, we believe that it will be about 150 billion US market by the end of 2026.
Николас, спасибо большое.
Thank you, Nicholas. And now we are moving on to another area. So we looked at how healthcare system look at this by the international system, at the AI, how venture foundations look at it, and companies that implement it. And now I'd like to go to the big transnational vendors. Hans Alois Wischmann, so the head of the AI department of Royal Philips Company. And so to learn what kind of projects, what kind of application, and what are the areas. So what do you think about artificial intelligence and what can it give to patients and doctors? Hans, the floor is yours.
Thank you very much for that question, and thank you very much for having me. Unfortunately, my digital twin cannot give the presentation yet, so you'll need to hear me out for today. I will try to speak into the microphone. Next slide, please. And I'm grateful for the... Oh, I have a clicker. Wonderful. And I'm grateful for the segue that you provided to me, because I do want to stress how important the validation of these things is, because it is humbling to look back at data science even in the 90s, how easily you can be fooled. There was an example where a large clinic in North America was looking at TB patients that presented at the emergency department and was looking at 6-month survival. And the ones that had a prior history of asthma all survived or had a better survival than the ones that did not. So data science naively could have suggested, okay, they're going to survive anyhow. Those are the patients that you can easily send home. Unfortunately, that is a short-sighted view, because as it turns out, these patients received immediate attention, were immediately isolated in a dedicated ICU, and that's why they survived. So for us, it is as important as thinking about where do you get the correct data to train the original model to replicate and come close to or exceed human performance, as it is to see how that would actually materialize in workflows and whether it actually holds up to the promises. If you have an AI algorithm which has taken a few years to move from 80% accuracy to 85% accuracy, as a scientist we fall into the trap of being extremely proud, but then if you are humble enough to say, okay, but how good are the doctors actually, it turns out that they're actually very, very good. Missing one thing that may be clinically relevant in about 120 cases. So that is a hugely high bar for some of us and some of the ones that you just mentioned to try to pass. I'm trying to give you two very short examples, mindful of the time. It is along the lines of understanding, are we actually increasing patient outcomes? Are we improving the patient experience? Are we reducing the burden on the staff instead of increasing it? And at the same time, is there a potential to lower the cost of care? But even if you've done that with a solid validation, which is the pitch of my talk, you still need to look at adoption, and adoption comes with trust. And my second, more scientific example will go exactly into the problems of overtrust, where people can naively replace systems by AI systems, and undertrust, where many still say, oh, it's not good enough, the doctor will never be replaced. He'll be augmented, or he or she, but not replaced in our view. This shows the result of about 10 years of work. We initially worked on intensive care unit data, trying to understand the degradation of patients and to try to create early warning indicators for these patients. So it's not the hyped image processing that you typically think of. These are mundane vital parameters, including information from the medical record that is pulled in lifetime. We've tried to extend that into the general ward, where tight-looped surveillance is typically not the practice, and try to add AI on top of the guideline-based care. In that combination, We then invested into a validation after having thought through the physics, the mathematics, the model building, the available retrospective data. We invested in, with a clinical partner, into a prospective study, and we were surprised and actually blown away. This is thousands of patients, and what you actually see is if you do it right in alerting the clinicians in a meaningful way on the general ward, you can reduce the cardiac arrests on the general ward by 86%. That's 5 out of 6 that are removed. Even more, without increasing the referral back into intensive care, those patients which you do refer back die with relatively fewer percentage. So it's 2/3 relative reduction in mortality in the patients that go back. So the quadruple aim that I mentioned earlier, this saves patient lives. Better patient.
Я говорила о том, что это позволяет спасти человеческие жизни, и это обеспечивает более качественный опыт пребывания и вообще состояние пациента. То есть это те элементы, которые являются необходимыми для того, чтобы обеспечить валидацию, прежде чем развертывать все эти системы и использовать их.
Connection to what you were mentioning earlier. This is an article that was recently published in Nature. It got a lot of attention in the TV, in the news, among scientists, and I'm not trying to bash this article in any way. I find it is a very interesting point where we can sharpen our own arguments and learn for ourselves. To the team's credit, they did not claim that it was ready for clinical use, although it was pitched that way in the mass media in some instances. It is partially because the authors in their summary said, we have developed an algorithm which can do mammography reading better than radiologists. So I copied the main picture that they had here for the UK as an example for overtrust and undertrust. Undertrust, I could say, well, there's so much wrong with the methodology, let's not take it seriously. Totally wrong, because actually the system that they have clearly outperforms the first reader in the UK in mammography, as this very technical curve shows. The green arrow that I added shows that actually in the UK, you don't let mammograms be read by a single radiologist. There's a second radiologist, the blue dot here, which always does a second read, and if the two don't agree, there's a consensus process to get to a consensus solution. You see, perhaps if you're trained in reading these scientific diagrams, that the second radiologist already outperforms the system. Even more, with the consensus on top of it, the consensus reading, as is the standard of care in the UK and in a few other places, outperforms the algorithm as much as the algorithm outperforms the first reading radiologist. So there's both extremes here. If I fail to recognize it, it's a missed opportunity, because the algorithm alone is as good or better than a single radiologist. The authors go on to argue, indeed, the second reader may not be necessary if the algorithm agrees with the first reader. And then you may be able to reduce 40% workload, because 80% in the second reader may not be needed. But if you naively replace a well-established system, the red dot here, by the AI system, and you stay at the same sensitivity, you'll be actually doubling the false positive rate. And in a screening scenario, that is totally intolerable. So again, validation. We need to invest into validating what we've created beyond the hype that we create in the public media, in getting attraction of investors. We need to actually, unfortunately, go back and read the scientific publications. And we as a company are taking that extremely seriously, and we're honored to be working also here in Moscow with partners in not just creating the solution together, but in validating it on the population and making sure that we're not decreasing care by blindly believing in AI. On the other hand, if you do it right, it does help, in our view, alleviate the shortages of radiologists that we have, get the quality care at a consistent level into a wider network, into a wider spread. And so we believe in the technology, but we believe, or we're convinced, that you need to invest into the validation, and that it's not good enough to just have it as your own proof point, as your own example, and you tout that through the media. That was essentially my pledge for making sense out of AI in healthcare and getting it right.
Ханс, большое спасибо за доклад. Мы такой провели...
Thank you very much. So it was a very good walk through artificial intelligence all over the world. And now let's get back to Russia. And I wonder what we can apply here in Russia from what we heard from our international experts. We have been working with AI for quite a long time, and I would like to ask my question to Sergei Morozov, who is a representative of the Health Department, and he is one of the first people that began to work with this. So, Sergei, could you tell us more about the initiatives that you started in Moscow, and what kind of changes have you observed? Thank you, Sergei. Thank you for this very interesting session. I need a clicker. Artificial intelligence begins to be used as a practical tool. Where can we see artificial intelligence? You know, we will find it in our kettles and toothbrush. Whenever we see a sticker AI assisted, it means that there'll be more consumers that will be willing to buy it. So in terms of marketing, it's all fine. As to some specific services, I think that the investments into some specific services are finished. And this is what we saw at RCNA Congress in Chicago recently. And companies go to vendors that produce medical equipment, and it's quite obvious. So it's either the producer of radiological equipment or the producer of radiolocation system. So I hope that very difficult procedures that we have will allow this, and it's X-ray device that shows the image, and it could show pneumothorax straight away. So it's not the radiologist that sees it. It can be used in intensive care unit. So any specialist can look at this image, both the doctor and the nurse. So if they see the signs of pneumothorax, they will make records about this, and it reduces the time of diagnostics. Yes, they will receive a report from the radiologist, but it will come later, and and this will happen because they will take some fee for this. So Hans Alois demonstrated it very well when they use the algorithm and when they connect it with their equipment, and this is the future trend. So a new mammographer will have to have a function for automatic imaging and visualization. So Moscow project has two companies that are going to be part of this testing. So they're going to use computer vision, and it's quite difficult how to analyze this data, but we are describing this methodology. We are delivering webinars and publish different articles. Anastasia Rakova announced the start of experimental project to check the precision of algorithm and how they can be used in medical practice. Briefly speaking, The data is available and accessible. We have very good computational facilities. We no longer need genius data scientists. We just need very good data scientists because algorithms have become more accessible, and the services to learn algorithms, to get training, are available. So any school student can get some Python training to identify mammal cancer. So there is a lot of data and a lot of companies. You know, it's difficult to create a service. AI use is very wide. And it's about $3 billion as compared to surgery that could reach tens of billions of dollars on the market. But anyway, the usage is quite varied and diverse, and it can help to minimize risks, to collect big data, to treat patients at home. Any kind of data, it doesn't have to be medical data. It can be pharmacological, financial, administrative, insurance data, could be automated for analysis. These solutions that we have on the markets are not related to pathomorphology or radiology. It's about diagnosis of syndrome of early child death, diagnostics of mouth diseases based on imaging. So there are so many fields of application and hundreds of companies that offer their solutions. So they want to get FDA. FDA creates conditions for accelerated registration, software as medical device, and there are more and more options every year on the market. But almost no one from this company had conducted clinical trials like they do with pharmaceutical drugs, when they identify how the drugs work, what kind of indications and counterindications have. So each algorithm, just like pill, has to have an instruction like indication, counterindication, possible risks. Then it will become clear for the doctor how to use the services. Now I'm going to show you 3 slides, which is the result of our analytical work, when we can see different business processes, and it describes the work of a diagnostician. Maybe you'll think that it's true and applicable only for radiologists, but it's not true. And you can see the problems that can appear at different stages, and these are the algorithms for each step of doctor's work, and it could help either to improve prescription, or to do testing, or to describe the pattern, or to identify pathology, or communication with the patient, or double check the quality. So each stage can become better, and it can help to process data much faster, so it increases the rate and the speed of this work. Many people say that this will help to give more time for the doctors to talk to patients, but I'm not so sure. And now I'm going to show you a possible scenario that you'll have to work much more while using artificial intelligence. For example, the radiologist has to look through 3,000 X-rays in order to detect just one case of disease, and the algorithm can automate all this work. And it's good if we relieve doctors from routine functions. There are many interesting components for patients, reducing time of diagnostics, and better satisfaction and better patient safety. There are advantages for doctors and researchers to devise new pathways, search for new formulas of drugs. It all has very important role. So now, speaking about the problems, first of all, seamless technical integration in clinical business process, then stability or consistency of work and reproducibility of results. We had some problems when the teams changed and the old team took some data away and new team lacked a lot of data. Of course, there must be a quality control, just like they have a quality insurance in production, and the reliability of results in terms of interpretation. So how does it work? The doctor does not see the pathology, whereas the algorithm shows that the pathology is possible. The good doctor will also look from the side. I mean, took a side angle to double check. And let's say the doctor thinks that there must be some problem, so they used CT, but nothing was confirmed, so they spent a lot of resources. If the doctor can rely on algorithm and say that there is no pathology with 100% confidence and certainty, then the patient won't have to go for some extra procedures and go for additional diagnostics. There are quite many problems related to data sets, availability, and the mistakes in formulations or statements. So lung tumor and can be shown as black and white spots on the X-ray. So this is what we have to do. We have to teach what's there when they work with the algorithms. But there's another danger, and I know this example from Israel. It's possible that some noise changes the algorithm, and this is the experiment that was published. The algorithm found some other pattern, so it has to be well protected. The algorithms can give absurd recommendations, and the specialists don't want the algorithm to have its own opinion. We can discuss whether it is the first opinion, the second opinion, but the algorithm should not impose something which is out of line with the practice used in the clinic. For example, in one case, the algorithm gave 40 tests instead of 7 tests. So it's a methodological question. The algorithms are not absolute, and this is an example from the company showing abnormal probability 0.87, and again it needs interpretation. But if there are 2 algorithms that confirmed 0.87, then we probably should trust it because there's a pathology, whereas if 2 algorithms said that there's no pathology, maybe it's not there, and we shouldn't waste doctors' time on analyzing these images, and it's yet we have to test it in order to see whether the algorithm can really reduce specialist time and reduce diagnostics time. So we had a competition, and Meshcherikova's company took part in this competition. They used a thoroughly devised methodology when we gave about 100 studies to the companies, and we asked them to give diagnosis, and then we compared the conclusions given by algorithms and doctors as well as ground truth. So we saw it in different way. One company showed that there were no pathologies in one way, another company showed it in a different way. So even the reflection of results or presentation of results can be different.
So data are all anonymous, and the accuracy is very different, sensitivity is very different, 0.6, 0.7, 0.9. You can use 0.9 and screening, so we can trust this, so that there is no pathology. But when the algorithm is very specific, like 1, so we trust it when it tells us like it's probably a tumor. So we understand it's not pneumonia, but a tumor. So it correctly tells us the diagnosis. So a doctor or a clinic receives such comparison of companies. What can they do with it? Nothing. It's just a question of this lab experiment. And so as a result of this, we can formulate where we can use this or that algorithm. So to contribute the development of this area, we opened a website, mosmed.ai, and at this website we upload all the methodology, all the topical standard information, and also some all examples of all the equipment that use AI. So CT, mammographs, they're all connected to this unified system. So to use AI services in the future, we should show what kind of image we have, what is DICOM, what kind of metadata it has, what kind of compression, what kind of matrix, all technical parameters. That's why we created this website, where the company developers can download everything they need, test if the algorithm are working, can they work with such data, and then come to Moscow government to offer their digital services to implement and practice. So there are many pathologies, mostly now focus of lung cancer and breast cancer. So it's mass studies, but we are planning to use wider cases to test algorithms. Here you may see some animation, but it shows what we want. So we want that doctor, when receiving a study for description, will get at the top upper part what he should check first to create this description faster, then show where this pathology is, compare with previous studies, and to create the template of description, so to make the work of a professional faster. So it's all based on DICOM standards, HL7 language, to make these systems open for international cooperation. So we are forming databases. It is becoming the most important topic, and we also classified like this data sets. So small data set, depersonalized, marked for self-test of a company proof test. It's already for some data set for some proven test, so to make some clinical testing or calibrating. So why is it important? Because in Moscow, breast cancer and overall in Russia, mostly it's detected on second or third stages. Unfortunately, when it's already quite big tumor, companies that come from other countries, they have another ideas. So we can find calcinates, microcalcinates. No, thank you. It's quite rare for Russian patients. Russian patients mostly have some volume in breast. So we need services that can look for volume. And so this proper task setting is very important, as well as some adjusting. Transfer learning to continue teaching AI services for the specific patients. And then data set for training algorithms, at least 5,000-10,000 studies. Now we have the whole matrix of depth of markup from binary to multiple components, depending on the variety of complexity for different integration. So there are many areas. The focus is on practical application. Now we have a specific working group for AI in healthcare. according to the order of Russian Standard Agency and started the work to standardize clinical and technical tests, trials and methodology of work with algorithms. So what's happening on the market? We see more and more platform solutions, platforms that come to clinics with the whole set of algorithms. It's hard to agree with every company separately to make tenders. Just give me a complex solution that I can either cover everything or choose some. So Philips now has such an offer, and other companies on the market. Most of the companies who develop services want to be at such platforms, and I hope that Russian developers will also be present at such platforms. And so in the future, we expect automatization, standardization, when a doctor works together with a robot and keeping personal communication with the patient thanks to automation of some extra functions. Not forget that any system, Google, Yandex, or any other respected services, it's not a doctor, and we should first come to a doctor. Thank you for your attention. Thank you, Sergey, for such a very comprehensive report. You really made a huge work and a lot to do. Yeah. I saw that about the number of diseases. I think the plan is big and so many things to do. Now I'd like to ask Olga Belarus. It's a person who leads the Medical Informational Analytical Center in the Yamalo-Nenetsk Autonomous District in the north, where there was a very interesting project related to use of AI technologies. And I'd like to ask Olga about details, how it was organized, how did you pick this solution, what are the results, and what are the prospects for this project. It's very important that such a work is done across the whole country, not only in Moscow. It's clear that Moscow is ahead for many things, our region, but we have and accumulate quite a lot of experience in regions as well. It's very nice. So good afternoon, dear colleagues. Thank you for inviting me. I'm very glad to present the experience of our region at such an event. So looking at the AI technology application in our region, we understood that using the benefits of this technology, of course, we will have some barriers. And such barriers like lack of clinical proven efficiency, when doctors are not ready, when they're afraid of being replaced, or the fear of total control. So there were quite huge barriers that can impede the implementation of the projects. Nevertheless, in our region, the prerequisites were quite good for implementing such a project. We have quite a good level of informatization in the healthcare area, and we decided that we need all the foundation to start such work. So our tasks were to select several products to try. So prevention is like the main trend in healthcare. We needed some competent and reliable partner. We had to make a pilot very fast without sufficient funding, and to achieve some results for a reliable partner. Our region has a peculiarity. We don't have universities, we don't have educational base, we don't have medical institutions that can have any competences of the federal significance. So that's why we needed support of competent partner, and we addressed to a national database of educational science. And so we had support how to make medical solutions with AI support at Open Innovations. And the winners of this contest became our partner. And in November, we invited the representatives of the companies who were developers. So these are the winners. Botkin and WebBiomed that we tested in our project. I'd like to speak more about some organizational approaches to the project. So we made some session where we invited some medical community, so representatives of medical institutions for areas that we were planning to use in this project, and the representatives of the Department of Healthcare. As a result, we got the support of the medical community, of the heads of the department, and on December 12th we signed a cooperation agreement between the association and the region, and on December 26th we had an order of the Department of Healthcare about the launch of this pilot project. So this project defines the tasks and objectives, and so we had to find the risk factors of cardiovascular diseases and detection of oncological diseases using images. And we found the medical organizations for this pilot project and curators of the project according to these areas. Then we had to go to some practicing doctors to get their support and to start the project. So after adjusting all the solutions and calibrating, we went to some pilot organization, some municipal hospital, where we may organize the session, talked to doctors what is AI, what are the prospects of using it in healthcare, and showed already some real place of a doctor, how he can work with the AI. Here you may see some screenshots of medical information system. So you see that now we have an icon to use AI, and the feedback from the system that AI assessed the risk based on what methods it made this assessment and what risks were defined. So within this pilot project, doctors provided their feedback to the developers that were used to improve systems algorithms. Within this pilot project, about 60,000 times they used AI. To train AI, they used a database with 37,000 patients. So it's a huge amount of data, about 1,300,000 medical documents. On the left you can see the dynamics of using AI, and so the peak was on days when it was at night without the use of doctors, and they use the whole data set of the hospital. So interestingly, the doctors themselves assessed AI work, and you can see it at the left, at the bottom, and mostly they assessed it as perfect. Within this pilot project we made 2 studies. One of them was comparative studies. Here you see the results. The purpose of the study was to compare the assessment made by doctor and by AI. And so there were 4 methods, and what did we get? That when they had the same assessment was only in 51% of cases when AI and doctors made the same decision. We had 3 categories of doctors in this study. Cardiologists were the best, so they had about 65% when it coincided with AI results. So even such typical methods like SCORE are not accurately used by doctors all the time. And there's a study that we made. It's a retrospective assessment of the regular checkup results. So we checked the medical records of the same hospital, about 5,500 of these medical records, and we assessed risks and the health groups. Here you may see two assessments. At the top you may see the assessment by doctor, and at the bottom by the AI. So you see that a doctor found 4 risk factors and the risk was considered moderate. AI treated the same information, found 8 risks, and the risk group was already defined as high. And according to the integrated assessment, the total assessment is a very high risk. And so for this patient we have data in her medical record that after this regular checkup she came to the medical facility, and so AI was right. So the results, the findings of these retrospective studies showed that doctors miss some risk factors. Only in 37% doctors found all the risk factors. Most quite often missed the risks in front of you. So the correctness of risk assessment according to group, so it's different quite significantly. So Webiomed found 7 times higher patients with high risks than doctors. So according to SCORE assessment, doctors put patients with low risk into high and very high risks. So what's more important that so what can we say about it? So doctors within their routine work make mistakes due to some objective reasons, lack of time and some other factors, and that's the niche that AI can work better and make the small task much better, and it will be a good support for doctors. Overall, as a result of these studies, the hospital received so all the database of all the people who come to this hospital, structured data set. So now they have lists of people of high risks. Then this hospital worked upon this list, and as a result of doctors' commission, so physicians invited people, and 112 people were additionally studied, and 300 patients were invited for some additional tests, and 93 were invited for these regular checkups. Another area is oncological disorders. So we process data from the central archive of the medical images. So 1119 series of CT of chest CTs in one of our hospital. So AI suspected pathology in 45 patients in CT, and the results were reviewed by our radiologist, and in 25 cases they confirmed this diagnosis, and 2 cases were defined for the first time. So the results of the pilot project finalized at the conference that we had in Salihard in April 2019. So they were confirmed as positive, and based on that we continue our pilot project. And this year we'll join 6 more hospitals to this Webiomed, and all the images that are coming to the archive are now detected by this Botkin program. Also got the educational moment for doctors. After our example, we asked about the methodology, how to assess cardiovascular risks.
and our data was used to prepare the report on infection prognosis and shared it with the Association of Cardiologists. We also shared the effective use of medical images and electronic records. It was one of the few IIT projects that basically involved just one instrument and no extra work was required. According to our pilot project results, we prepared reports for the Agency for Healthcare Supervision. And one more outcome is that we destroy the barrier. I mentioned earlier that the doctors are afraid of using this technology. They don't trust it. They think that the doctors will be replaced. But I hope that the doctors understood that the doctors could use AI effectively and become a more successful specialist. When we speak about future and innovations, our doctors want to use similar technologies for other areas. Thank you for your attention. Thank you, Olga. Great results. And the good thing is that these outcomes came from somewhere else, outside of Moscow. Because I can see that there's a competition between different regions of the Russian Federation, and this will be good for technologies development. This healthy competition between the regions for the quality, for the development can bring only good results, and it's only for the best. I hope that Mr. Sorokin would tell us about the project implemented in their district, but Olga has told us a lot about it, so maybe you could just add something. And one more interesting thing that Sergei touched upon is about transfer of data from one place to another. Sometimes the system loses its precision, so I'm interested in technological approaches. What can we do to make automation better for the replication of such solutions? Okay, thank you. Let me thank Olga. And I would like to thank you not only for her excellent presentation, but also for excellent pilot projects organization. And we were very proud to take part in them in Yamalo-Nenets district. And this brought about daily use of two tools, two products that Olga told you about. And it's true that there is a competition between the regions. I'm sure that Moscow is doing a great job, and they're doing it on a different scale, and maybe there'll be a competition not only between the regions, this, so to say, the race, but also this race will be between the countries. And I'm sure that we will witness similar projects in different countries. I wanted to take a step back to share some comments about our project development. it's not only a success story, the story was full of problems, and Sergey was right when he said that algorithms and models became available for a wide range of developers. So the threshold, went down, and I guess any student, student that specializes in IT probably could develop an algorithm. We started 3 years ago. We didn't have such instruments, but we could do something quite fast, maybe not as good as we do it now. And we created our first models, which we analyzed. They analyzed neoplasms in the lungs, and when we approached the clinics, we saw that what works on our data sets in our regular environment doesn't really work in the clinics. And that's why we wanted to attain sustainable results, so that the models could show stable results while being used in different environments and with different equipment. There are quite many factors that produce non-stable results. But at the moment, we are very proud that we reached a very stable result. I can't say that there is some kind of a silver bullet that can enable us to create a universal algorithm that would demonstrate stability on any data sets. It involves a range of different solutions related to very effective and precise calibration. Whenever we use our algorithms in a clinical environment, we have to change the model. And how can we do it faster? What kind of means and tools can we use to make it work effectively? This is the main thing to ensure an effective service. And then the next question is how to fit in this service within the existing processes in radiology and how they all can be used. So when we started it, we set a goal to achieve measurable results and show what a clinic or a region could get while using our platform. There is a very good study that shows how many cases of malign neoplasm could be missed by a radiologist. And as part of lung screening, doctors had a CT of their chest. So whenever they diagnosed the lung cancer, they would go back in time to see whether it was missed, and they wondered whether they could identify lungs cancer at an earlier stage. And in 50% of cases, they could diagnose cancer 1 year before. So we try to address this issue in our pilot projects. And another problem common to Russia as well as other countries is the shortage of radiologists. And you can see an extract from a scientific article that shows the shortage in different regions of Russia. So, but most countries have more or less similar figures. So what did we do in our region? We used the archive of medical images and reviewed CT in order to see if there were any patients that could have some neoplasms. And then we would show our results to radiologists to see whether they would agree with our findings or not. So this happened last year. We worked in 3 regions. Now we have over 10 regions that work with us, and we found 15 patients out of 1,500 that had malign neoplasm, which was not early diagnosed. So here you can see our platform solutions that can enable you not only to analyze and review the materials, but it can also be embodied in different models of work. For example, teleradiology has become very popular, and there are goals that have to be met, such as precision of analysis. And all AI solutions should have different functions, so that the radiologists didn't have to work with many screens, jumping from one screen to another. They must be integrated solutions, and they have to be integrated in the procedures and the processes, as well as software and hardware, which is already operating in clinical environment, or will appear there in the future. And of course, they should be able to identify as many pathologists as possible. But we can do it very fast. We can add more pathologists. The most important thing is to build a platform that could be comfortable and convenient to use. Thank you. So we moved on to the technological part of discussion. Now we are speaking about technologies and not just doctors and doctors' opinions. And now I would like to give the floor to the representative of the bank. They call themselves startup, so they develop different technologies. Pavel Litisan, who is the head of Sberbank Laboratory for AI. Tell us, please, what you're doing globally, how you apply your developments, what kind of initiatives you come up with. Thank you for your question. I guess we are running out of time, so if you could be brief, it would be great. Yeah, I'll try to be fast. AI laboratory was set up 2 years ago in Sberbank. And we started working with medical help just last year. You know, somebody said that any student can develop a model, but I can tell you that it's not that easy. Speaking about mammal cancer, you can have 1% of cases, but you need 100,000 of data set items. So it's a very difficult task. And many startups couldn't cope with this. So our AI laboratory has a team of 10 people, so we are looking for different methods of AI use for medical care. We try to use different options and different fields. One of our major fields is using AI for analyzing medical imaging. And we built a model that can detect a stroke on tomographs as well as 10 radiologists could do. We also analyze mammal cancer and electrocardiogram. We are also analyzing electronic medical records. And this is a very interesting work for us because there are many people that work with radiology. There is a MICAL conference that is a leading conference, and I think they published over 1,000 articles about it. We are more interested in medical records analysis, and we have already achieved quite good results, but I'm not going to tell you about them. We need to confirm them. I can say that Moscow has about 5,000 medical data scientists. 5,000 data scientists, and only 1% of them would be medical data scientists. So it's a quite small community of specialists. It's very important to introduce this and to analyze it all. But I can tell you as a practitioner that there are so many challenges, and we need help from medical community to identify the goals, to give the clear formulation so that it could bring you some benefits. Thank you. A very good, very brief address and inspiring address, and I do support this because the Skolkovo Foundation actually helps startups to work with large corporations, so the data scientists could find some work for them. The next report will be given by Anna Meshcherikova, and the company called Третье мнение, Third Opinion. And it's not by chance that I decided to give the floor for these two speakers, because Anna became a winner in the Sberbank competition. It was a cross-industrial competition, but it was focused on medical care in particular. So tell us about your system and what you do at the moment, and what we can expect in the nearest future. Good evening, colleagues. Since we are running out of time, I'd love to tell you about outcomes and not about the future. I would also like to tell you about our pilot projects that we delivered last year. So our company is called Третье мнение, Third Opinion, and we develop AI services for healthcare. So you can see the map or the image of different services that we develop, and they're not only about pathologies based on medical imaging, but it's also a service that work like digital assistants for nurses. So these two groups of services are common in their drivers, because we do think that these services are needed by healthcare. They're in high demand because they address issues that the shortage, where we have shortage of specialists, because we have a shortage of doctors and the nurses in certain spheres. So that's why we decided to address these areas.
So this year in 2020, it's almost 50% higher. So 33% of the budget is for these regular checkups. So as for detecting pathology and medical images, AI can bring the most benefit in terms of these regular checkups. So when there is a huge flow of patients, and potentially a very huge flow of patients who are normal, who don't have any health issues, and today Sergey quoted an example, and when you look at chest X-rays, to detect one case of TB, you have to look through 3,000 chest X-rays. So today I will tell you about a pilot project in Krasnodar Krai, about its case application, so AI recognition and screening of the chest X-rays. So today we presented to our pilot customer oncological dispensary the service for the pilot implementation to detect 15 different pathologies, and we expected to receive some effect. As for the accuracy and specificity of the algorithm and the possibility to use it in this region, we got the results. The pilot is over. Using the data that we received, we got quite good result, quite high results. So these results allow us to register this module as a medical device. So we got the recommendations and some comments how to adjust the module and assess the effect of the possible implementation of this module into screening program for this region. So how did we come to this number? So we get this economical improvement from 25 million rubles per year. We analyzed the number of citizens that go through these regular checkups, and chest X-ray is part of these regular checkups. And so we use this necessary medical insurance tariff for specifically for this part related to reading of this, and 38 rubles per one chest X-ray. And so it could take into account the statistics, how many people are normal without deviations, and that these procedures can be transferred to AI for reading and sorting. That's how we got this result of economical efficiency if we use this module. The second solution that I'd like to present you, it's AI monitoring module that allows to assist not only doctors but also nurses, even chief nurses and treating doctors to control the process, care protocol and processes. So this module presents process of understanding video flow from the patient ward, and allows to detect, monitor, and to send some notifications about significant changes that relates to the patient, the position of a patient in bed, but also some authorization of medical personnel, and the recording of some significant medical event that a medical nurse is supposed to do at some time. So we made a pilot project in the Pirogov Medical Center. This project is done. The results are very high, very good. And the result of this recognition, so this patient position and the presence of medical staff, some manipulation by nurses. We received such huge, such a high precision of AI work, and positive conclusion and recommendation by this medical surgical center to scale this decision in Moscow. So our team has very important seasonal professionals in medicine and computer vision, and to support what I said about and what was being said about students who can develop algorithms and the necessity of some serious competences. I'd say we are sort of in the middle, and I think it's important. So both groups are important, and our group of researchers represent Moscow State University School, and we have the possibility to work with students of programming course department in the State University, because Anton Kanushin is the leader of the chair in Moscow State University related to programming. I'm very happy that according to the result of 2019, the company and our developers took a 6th place in top 10 companies in Russia that work with computer vision, and our consultant takes the 2nd place among top 15 Russian researchers in computer vision. So we hope it will give us an opportunity not only to create new algorithms, but also to provide stability of their work during the whole process of their use at the ready solutions. Thank you, Anna, very much. So here we should wrap up our session, but there is one interesting fact. We have a very respected radiologist, Paul Plazier, who headed this community in Europe and in top 10 of other radiologist community in the world, and I'd like him, Paul, to maybe to sort of make some conclusion, to tell us a couple of words, because it was very interesting review from the whole world. Paul, the floor is yours.
Спасибо большое.
Thank you very much. Good evening. I don't much.
First of all, first impressions, congratulations to the Moscow Health Assembly for having this. This is really visionary. I think only a year ago or 2 years ago, this would not be possible. And I don't think there are many countries in the world that are doing this. So congratulations to this panel, to the speakers. Congratulations also to the fact that what we've seen today is bringing together people from very different professions. We have seen people from the medical profession, but as we know, this is driven not by the medical profession, this is driven by engineers. And we've also seen people from the financial world and from the business consulting world. We've heard a number of the issues. We've heard prioritization of work lists, where should we direct our attention to? We've heard about offering care to a broad population. I currently work in Australia, which is a country similar to Russia, where we have huge challenges to bring healthcare to outlying populations that may not have access to the same services that you have in Moscow or that we have in the big cities in Australia. We've heard also a lot of focus on detection of malignancy, detection of tuberculosis, detection systems that can help doctors to actually help patients better and to overcome the shortage of radiologists. I think that's an important issue. And the final thing that I don't know how many doctors are in the audience, how many radiologists, how many other clinicians. There's a lot of fear in the medical community for all of this. Because medical doctors traditionally have been trained to be individualists, to take personal responsibility for patients. When I talk about AI, I always compare it to a GPS system in your car. 20 years ago, we were using a map or a compass even. Now everybody is using a GPS system or a smart phone with an app, Yandex or whatever, Waze or whatever you like, it is not replacing the drivers. It is helping the drivers to avoid the traffic jams, to be more efficient, to be better, to find new routes. And I think this is exactly where AI is going to go. And I think it's a very exciting development. So congratulations to the chairman and to all the speakers.
Поль, спасибо большое.
Thank you, Paul. So now our session is closed. Thank you very much for very interesting reports, very comprehensive. Thank you very much.